If you've been told you have a perianal fistula or abscess, you're probably terrified and confused about whether you need surgery right now or if there's another way. And here's what most doctors won't tell you about timing. Hi, I'm Kate, and today we're talking about perianal fistulas and abscesses, specifically how to know when drainage is enough and when you need to escalate to biologics or surgical intervention. And this matters right now because the decisions you make in the next few weeks can affect your comfort, your continence, and your long-term outcomes for years to come. When my son was first dealing with a perianal abscess, I remember that panic. The pain was unbearable. He couldn't sit, couldn't sleep, and the surgeon said, "We need to drain this today." But the GI said, "Let's see if the medication works first." And we sat there thinking, who do we listen to? I see this confusion all the time. Someone's been managing their Crohn's okay, and then suddenly there's this excruciating pain, maybe some discharge, and they're bounced between their GI and a colorectal surgeon with completely different opinions about what to do next. You feel like you're supposed to choose between two specialists who aren't even talking to each other. And meanwhile, you're in agony and terrified of making the wrong call. Here's what most people don't understand. Perianal disease isn't just another Crohn's complication. It's actually a separate clinical beast that requires its own treatment strategy. The confusion happens because there are genuinely two different problems, and they're happening at once. There's the immediate problem, an abscess that's causing pain and needs mechanical drainage. And there's the underlying problem, active Crohn's inflammation, that's creating fistula tracts and preventing proper wound closure. Most people think it's either or. Either you drain it or you start biologics. But the real answer is usually both, just in the right sequence and timing. The mistake isn't choosing the wrong treatment. The mistake is not having your colorectal surgeon and your gastroenterologist work as a coordinated team with a clear plan for both the immediate issue and the long-term management. When these two specialists aren't communicating, you end up with repeated drainage procedures that never fully resolve because the underlying inflammation isn't controlled. Or you end up on biologics while an abscess is still there causing damage. So let me walk you through how to navigate this, step by step. Step 1. Understand what you're actually dealing with. An abscess, well, it's a collection of pus. It's an acute inflammation and infection that needs drainage. A fistula is an abnormal tunnel between your bowel and your skin, or between two parts of your bowel. Sometimes you have just an abscess, sometimes just a fistula. Often you have both. The key distinction is this. Abscesses need mechanical intervention, meaning drainage. Fistulas need mechanical management to address the inflammation that's keeping the tunnel open. Here's what to ask your doctor. Do I have an abscess, a fistula, or both? And if there's a fistula, is it simple or complex? The last part matters. A simple fistula is a single straight tract. A complex fistula involves multiple tracts, high positioning near the sphincter, or connects to other structures. Complex fistulas almost always need both surgical and medical management. Step 2. Know when drainage is urgent. If you have an abscess that needs to be drained, it's not negotiable. An undrained abscess can lead to sepsis. It can create more fistula tracts and it will cause unbearable pain. Here's when drainage is urgent, meaning within 24 to 48 hours. Severe escalating pain that's not controlled with pain medication, fever over 38.5 degrees Celsius or 101 Fahrenheit, visible swelling, or a lump near your anus that keeps fluctuating. You can't sit, can't pass stool, or you're starting to feel systemically unwell. In my son's case, he had all of those signs. The drainage happened that afternoon, and the relief, well, it was immediate. But here's what they also did that mattered. They placed a seton. A seton is a surgical thread that keeps the fistula tract open so it can drain continuously and doesn't reform an abscess. It's not a permanent solution, but it's a bridge that buys you time while you get the inflammation under control. Now, this is a question to ask your surgeon. Will you be placing a seton, and how long do you expect it to stay in? So, step 3. Recognize when medical escalation is necessary. Drainage alone is not enough if you have active Crohn's inflammation driving the fistula. If you drain an abscess but don't address the underlying disease, you'll end up back in the same situation within weeks or months. Here's when you need to escalate medical treatment, usually to a biologic like infliximab. You've had more than one abscess or fistula in the same area. The fistula is complex or high. You have active Crohn's inflammation elsewhere in your bowel, and the fistula isn't closing after drainage and seton placement. Biologics are not a last resort for perianal disease. They're often the most effective tool to get fistulas to close and to stay closed. My husband had 3 Crohn's surgeries before biologics were widely available. His perianal disease was part of what drove those surgeries. Today, with the medications we have now, many of those surgeries wouldn't have been necessary. So here's what to ask your GI. Given that I have perianal disease, should we be escalating to a biologic now rather than waiting? And if I'm already on a biologic, is my current dose and frequency optimized for fistula closure? So step 4. Make sure your team is actually talking to each other. Now, this is the step most people skip, and it's the one that makes all the difference. Your colorectal surgeon and your gastroenterologist need to have a coordinated plan, not just separate opinions, an actual shared strategy. And here's what that looks like. The surgeon drains the abscess and places a seton if needed. The GI starts or optimizes biologic therapy to control inflammation. They agree on a timeline, usually 8 to 12 weeks, to reassess whether the fistula is closing. If it's not closing, they discuss next steps together: dose escalation, switching biologics, or surgical advancement flap procedures. Here's the question that forces coordination. Can my GI and surgeon have a joint appointment or phone call to create a treatment plan together? And can someone document that plan so I know what we're working towards? If either doctor resists this, well, that's a red flag. Perianal Crohn's is complex enough that it genuinely requires team-based care. Step 5. Support the process from your end. While your medical team is managing the acute situation, there are things you can do to support wound closure and reduce the risk of recurrence. So here are some practical steps. Keep the area clean and dry. Have baths with salt water 2 to 3 times a day. Avoid straining with bowel movements. This means managing constipation or diarrhea aggressively. Optimize your nutrition for wound healing. Adequate protein, zinc, vitamin C, and vitamin A all matter. And manage stress. I know that sounds impossible when you're dealing with this, but chronic stress impairs wound healing measurably. And here's one most people don't think about. If you're on prednisone, talk to your doctor about tapering as soon as it's safe. Steroids impair wound healing. They might be necessary short-term for controlling inflammation elsewhere, but they work against fistula closure. So here's the question to ask. Is there anything in my current medication list that might be impairing wound healing? And can we optimize that? So, let's come back to where we started. If you've just been told you have a perianal fistula or abscess, you don't have to choose between waiting and emergency surgery. What you need is a clear plan that addresses both the immediate drainage and the underlying inflammation, with a timeline, with coordinated care, and with realistic expectations about what closure looks like. For my son, it took about 3 months from drainage and seton placement to fistula closure on a biologic. For my husband, before biologics were available, it was a much longer and harder road. But in both cases, having a clear plan and a team that communicated made all the difference between repeated crises and actual resolution. You can get through this, but you need the right support and the right questions. So, if this helped, share it with someone who's dealing with perianal disease right now. They need this information. And if you want more specific support navigating Crohn's complications or working with your medical team, that's exactly what we do in the Crohn's Method community and in my one-on-one coaching. I'll see you in the next video. Have a beautiful day.